Hello everybody, I'm Dr. David Andreone. I'm a podiatrist at UT Health East Texas in Tyler, and I'm going to lecture you today about the diabetic foot and hopefully everything you've ever wanted to learn about it. So first you might want to ask, what is diabetes? Well, it's a chronic metabolic disease in which the body does not produce or properly use insulin. It's known as the silent disease because by the time it's diagnosed, it's been present for at least 7 to 10 years. It's the 7th leading cause of death in the United States and claims more lives each year than AIDS or breast cancer. By the first quarter of this millennium, there will be more than 300 million people worldwide with diabetes. And diabetes in America, there's about 15.7 million. 10.3 million of those are diagnosed, and then another 4.5 million are not. So every minute, at least one person is diagnosed with diabetes. So you might be curious as to what the cost is of having diabetes. Well, it's the leading cause of hospitalization for approximately 8 million Americans, resulting in expenditures at over $200 million annually. 89% of those have hospital stays greater than 1 month. 44% have hospital stays greater than 3 months. 6.3 million of the 38 million people enrolled in Medicare programs have diabetes. That's a pretty significant number. And Medicare provides coverage for therapeutic footwear such as extra depth inlay shoes, custom molded shoes, shoe inserts for people with diabetes who qualify under Medicare Part B. People with diabetes tend to have a lot more than just foot problems. That tends to affect a lot of the different systems in their body. Heart disease and stroke is one of them. People with diabetes are 2 to 4 times likely to have heart disease, which is present 75% of the time in diabetic-related deaths. The risk of stroke is 2 to 4 times higher in people with diabetes. Kidney disease is another common complication. Diabetes is the leading cause of new cases of end-stage renal disease, accounting for about 40% of new cases. Blindness is another complication associated with diabetes because it's the leading cause of new cases of blindness in adults 24 to 74 years of age. Each year, 12,000 to 24,000 people lose their sight because of diabetes. That's a significant amount of people. More along the lines of what I'm going to speak to you more about today would be ulcers and amputations. During their lifetime, approximately 15% of diabetics will experience a foot ulcer, and between 14 and 24% of those adults with a foot ulcer will require an amputation. Here's just a couple examples of what you might see on a diabetic's foot, either before they have an ulcer or right after. The causes of diabetic ulcer are not feeling pain when you're walking, inappropriately fitting shoes, bony deformities like bunions, hammer toes, flat feet, or excessively high arches, friction from slipping inside your shoes in the case of having too large of a shoe on, and also walking barefoot. Along similar lines of cost of diabetes, the total annual cost for more than 86,000 amputations is over $1.1 billion. Yes, that's with the B. This cost does not include surgeon's fees, rehabilitation costs, prosthetics, time lost from work, or disability payments. These amputations have major predisposing factors which lead to them. You can see by the triangle on the chart. First, you have angiopathy, which is a decrease in circulation. Neuropathy, which is lack of sensation, or you can't feel anything. And those two things alone, with stresses provided from walking or shoe gear or whatever, can cause an infection or a wound. And so once you get those, because you're diabetic, you can't fight off the infections as well. You tend not to heal as well, so we have to be very careful with the diabetic foot as it's very fragile. There's 3 different kinds of neuropathy. The first one being sensory neuropathy. That tends to be along the lines of burning, numbness, tingling, and lack of sensation. The next one would be motor neuropathy, and it's just what it means. Motor meaning muscles. So you become weak, and that weakness can cause deformities because all of a sudden things aren't staying where they're supposed to be. And then there's autonomic neuropathy, the final one. That goes along the lines with temperature changes, swelling, change in sweating capacity, and changes in skin and nails. The sweating capacity just means that your skin's going to be very dry. And most diabetics tell me when they come to see me, I put lotion on my feet 2 to 3 times a day, and it just soaks it right up. And that's because they don't have the ability to sweat or to excrete oils through their skins as readily as everybody else. neuropathy. How do we test for it? Well, initially, if you come see your foot doctor, he's going to use a 5.07 monofilament. Looks like a piece of weed eater line. And this demonstrates minimum protective sensation. And if it's diminished, you should never walk barefoot and should frequently inspect your feet. They'll touch about 10 different points on each of your feet to see how much you feel. Anything 7 or above is considered normal. Anything less than that is considered mostly neuropathic. You also have an increased risk of punctures and wounds if you don't feel anything. I've often had people come in with nails through their shoes and they had no idea what was causing the problem with their foot. So often I tell them to check inside their shoes as well as check the bottom of their shoes to make sure that there's nothing going through the sole or there's no foreign body or foreign matter inside the shoe. The endpoint result of neuropathy can lead to a condition called Charcot Neuroarthropathy, or basically what that is, it's a severe case of neuropathy that left unchecked can cause significant deformity in a patient's foot. This is when the bones break and the person never gets the pain signal that a person who has good feeling in their feet would get. And that feeling in their feet would make them get off their feet and rest. Well, they never get that signal, so they keep walking on it till they basically break all the bones in their foot. Usually there's swelling and redness present. However, they're not having any fever or chills. What I'm trying to differentiate here between is an infection versus Charcot. Often one is considered an infection, and most people don't even consider the Charcot. And another test you can do to tell if it's Charcot versus an infection is also to do a white blood cell count, which you can check and see if it's elevated, then they might have an infection instead of that, or they could have both at the same time. The main point I want to drive home with the Charcot is that it's totally preventable if caught in time. Here's a picture of what Charcot can look like. You can see how the arch is flattened out and there's almost like a rocker bottom or a bulge in the bottom of the foot. That's because the bones no longer line up well and they've pretty much the middle of the foot has broken down. Doesn't look like it'd be very comfortable to walk on, does it? In patients who do have Charcot, these are some of the shoes that they tend to be able to fit into better. You can tell by looking at them, they almost look like they're going on the wrong foot, but that's actually the proper way they would go on because the arch is no longer up, it's down, and the foot is more along the lines of a C-shaped or crescent-shaped. Here's some reconstruction in a Charcot foot, where sometimes can be done and sometimes not. What can we do about neuropathy? There's several things we can do. First of all, there's medications like gabapentin, pregabalin, which is Lyrica, and amitriptyline. Those can help with the neuropathic pain. TENS units, which is transcutaneous electrical nerve stimulator. These can be helpful, and at some point in time they were covered by insurance, but insurance does not look favorably upon them anymore, so that usually they're not covered anymore, but some of my patients tend to buy some of their own and use them anyways because they do help. Another thing would be anodyne or infrared light. That is another modality that tends to help patients deal with the neuropathic pain. It doesn't work in everybody, but it can help. And once again, in recent times, the insurance companies, this has fallen out of favor with them. So some of my patients who tend to want to use this have to usually get their own device. The next topic I want to cover with diabetes is poor circulation. So you say, what are the signs of poor circulation? One would be cramping or pain at rest. Another would be color changes and temperature changes in the skin. The texture of the skin can also change and become tight and shiny. You'll notice that the hair growth is gone. But don't get concerned if you don't normally have hair on your feet or lower legs. Sometimes that's normal. And then the thickening of the toenails. These are all signs that the circulation is going down. Reduced blood flow in this situation can impair healing and also end up in having an amputation. So with poor circulation, or what we call peripheral vascular disease, you can notice that the discoloration on the right foot is compared to the left foot. Notice that the shiny skin is on the right side. Those are signs that there's an obstruction on the right-hand side. So what can we do for the peripheral vascular disease? Well, typically the first thing we would do is order what's called ankle brachial indice, or ABI. That tells me the measurement of your blood pressure measured between your ankle and your arm. It gives me a number. The closer that number is to 1 or slightly over 1, the better. You can see the values on there. 1 to 1.14, 1.4 is normal. 0.9 to 1.0 is acceptable. 0.8 to 0.9, there is some arterial disease. 0.5 to 0.8, you have moderate arterial disease. Less than 0.5 and it's severe or impending gangrene. Typically, even with my 0.8 and 0.9 patients, I'll refer them to a vascular specialist. Times have changed quite a bit over the years. It used to be that they'd have to do major surgery to open up the arteries. Now it's as simple as making a small little cut, and they can send a fiber optic wire down there and remove many severe blockages, and you can almost go home the same day. The next topic I want to cover is infections in diabetic feet. The problem with the diabetes is their immune system doesn't respond as well as everybody else's, so they have a difficult time mounting an immune response. So the body can't fight it off as well. So diabetics are more prone to worse infections and infections with more than one bug or bacteria. They may go undetected or worsen due to neuropathy and poor circulation, so they may not even know they have an infection. Why worry? Because most diabetic foot problems are totally preventable. You can see a picture of a transmetatarsal amputation on the right, and on the left, a patient of mine that had to have their big toe amputated after a severe infection. The important thing about diabetes is always laying eyes on your feet. So I highly recommend an annual diabetic foot exam so they can check for symptoms, medical, family, and social history, lower extremity exam for looking at your skin, your joints, your vasculature, and your neurologic responses. So we can also look at your footwear and assess those and see what your needs are regarding that. And then we can also give you the education that you most likely need to arm yourself so that you're better prepared for things as they happen, and hopefully prevent them from happening. So the warning symptoms for diabetes is diuretic symptoms, increased infections, abnormal weight loss, blurred vision, excessive thirst, tingling or numbness in your feet and in your hands, and extreme hunger, and then slow to heal wounds. Foot care tips for your feet. 1, check your feet every day. Sometimes twice a day is even better. Look at your bare feet every day for cuts, blisters, red spots, swelling, any signs of irritation. Use a mirror to check the bottoms of your feet or to ask a family member for help if you have trouble seeing. Check in between your toes. Make sure you dry well after you bathe. All these are very good things to do. Wash your feet every day. Wash your feet in warm, not hot water. If you can't tell what the temperature is, you can use a thermometer or something like that, or have a family member check it, because you don't want to end up burning yourself. Dry your feet well, especially between your toes. So if you can reach your feet and your sight is good and your diabetes is under control, use a pumice stone to gently smooth any corns or calluses. Trim your toenails each week or as needed, but don't let them get out of control. When you trim those toenails, you should cut straight across, and if you have an edge that you want to get to, just file it down a little bit instead of trying to dig into the side of the nail. That'll always cause an infection. Wear your shoes and socks at all times. No barefoot walking at all. People often say, well, I wear my socks. Well, a nail is going to easily go through a sock. So is a piece of glass or a piece of wood. Never walk barefoot. Wear comfortable shoes that fit well and protect your feet. Feel inside your shoes before putting them on each time so that you can make sure there's nothing inside the shoe that's going to cause harm to you. And the diabetic shoes of today are not like the Herman Munster kind of shoes from the past. As you can see from the picture here, they come in a lot of different styles that aren't so bad looking at all. Some of them are even like New Balance running shoes, which are very in style. In the middle, you can see how a shoe should properly fit and how it shouldn't fit. The one that's poor fitting on the right is definitely going to end up with some corns, possibly a blister, possibly an open wound. And we don't want that. We want to try to prevent that. So making shoe choices is very important. I often tell my patients to, especially my diabetic patients, to go to a place where they have a podiatrist or someone that's licensed and trained in how to properly get shoes to fit and to make sure that they don't rub and cause ulcers or cause blisters, and also to educate you on how they're properly supposed to fit. I'm going to help you do that as well, but they're going to make sure that the shoes are made properly. Foot care tips. Patients with deformities such as hammer toes, bunions should consider getting diabetic shoes which are specifically made to fit their feet and to give them room so that they don't rub or irritate their skin. In some cases, surgery can be done to correct some of these deformities, but not everybody's a surgical candidate. Here's a picture of some hammer toes. Sometimes surgical correction is necessary where we can fuse a toe, which would be on the lower right-hand screen, or in my patients who can't or are unable to have surgery, then we'll use some padding and shoe gear. You see a buttress pad on the upper right-hand side. The next foot care tip is to protect your feet from the hot and cold. Wear shoes at the beach or on hot pavement. And always, if you're concerned or you're not sure if something's going to bother your feet or cause a problem, always do what's right and wear a shoe. Wear socks at night if you have feet that get cold in the middle of the night. Another foot care tip is to keep the blood flowing in your feet. And you can do this by putting your feet up when you're sitting. Wiggle your toes and move your ankles up and down for 5 minutes, 2 to 3 times a day. Don't cross your legs for long periods of time, and don't smoke. The important thing about smoking is it can cause your arteries to occlude or be blocked off just as much as the diabetes can. So if you have diabetes and you smoke, it can be twice as bad. And don't drink alcohol in excess. So take care of your diabetes and try to be more active. Work with your healthcare team to keep your blood sugars within a safe range. Plan a physical activity program with the help of your doctor and also your podiatrist. The ADA guidelines for good glucose control is approximately 80 to 120 milligrams per deciliter before meals, 100 to 140 at bedtime, and hemoglobin A1C that's less than 7%. There's no perfect A1C, but keeping them within that range will always be to your benefit, because the higher that blood sugar goes, the more nerve damage and the more damage to the internal organs of your body is going to happen. But your physician will help you or direct you down the path and get you on the right medicines to help keep your blood sugars in that range. And that's going to be controlled by good diet and taking your medicines regularly. So if you know someone with diabetes, preventative steps for the feet start now. And for more information, you can go to uthealthieasttexas.com and the American Podiatric Medical Association, and they'll have a lot of different reference material for you about diabetes and your feet. And as well, you can also go to the American Diabetes Association at diabetes.org. So feet can last a lifetime, and that's a national diabetes education program. That's also a good benefit for anyone who has diabetes and is concerned and wants to learn more. And last but not least, here's a few questions we received through our registration page. The first one is, what can you do to keep toenails groomed so you don't get an infection? For an example, is it a good idea to get a pedicure? Well, that's a tough question, but a good question. Typically, I tell my patients if they can reach their feet and they can take care of their toenails, to keep them trimmed regularly. Just do a little bit each time, whether it be filing them down or actually clipping them. Some of my patients who don't have peripheral or vascular disease or haven't had any amputations in the past, if they want to get a pedicure, I think that's okay. I don't highly recommend it because there can be a lot of problems, but if there's a place you know that has the equipment, they sterilize it and they keep it clean and they don't do more than they're supposed to do, then it's possible to go there and have a pedicure and be okay. But you have to be very careful because you're at greater risk. I tell them if they would like to come in and have me do it, I can do it. In some cases, Insurance doesn't cover it. In some cases, it does. In those cases that it does not cover it, we try to make it affordable for people to come in and have that done regularly. The next question is, when should I be concerned about numbness or tingling if it's not continuous? Well, the numbness and tingling is a sign that your blood sugars are elevated. Usually when the blood sugar levels are high, those actually attack the nerve endings, causing numbness, tingling, burning, and eventual loss of sensation. The longer period and it stays elevated and the higher it goes, the more damage is done. And there is a point of no return. We can use some drugs like gabapentin or Lyrica to help deal with that, but the best thing is going to be to keep the blood sugars under control. That's going to be the key at helping keep the neuropathy at bay. The next question you had was, do you recommend wearing a certain type of shoe? For example, is it okay to wear flip-flops? Not a big fan of flip-flops, but there are some shoes that you can buy that are sandal-type shoes that have good amount of support, and they're actually safe for diabetics. That would be more along the lines of what I would recommend, as I've had several patients fall and either break a hip or break their femur or break their ankle wearing flip-flops. But as with any shoe, you need to be careful about what you wear, especially if you have balance issues or you don't have really good feeling. Then you probably want to be wear more of a shoe that gives you more support and protects your toes. Because if you walk around and your feet are in the open a lot more, you're more tend to injure them, scratch them, cut them. When should I start seeing a podiatrist? That is a good question. If you're diabetic, I recommend seeing your podiatrist at least once every 6 months to once a year. If you have more problems and you're more prone to injury and infection, then more frequently than that. But it's always good to at least to get a baseline and establish a relationship with a podiatrist so that you can know more about your feet and know what your risks are. And this way you can help prevent any kind of problems that might progress or happen over your daily activities.